And I thought while constructing this course, we would take up those two new things that have come up in the definition over the last few years. Essentially, a little bit of focus on the hyperosmolarity concept and on the anti-inflammatory concept. So we had two talks specifically structured for that. So is it a myth or a reality? And what I'll do is very quickly talk you through the concept of hyperosmolarity for a moment, and only thereafter. Now we know that dry eye is accompanied by hyperosmolarity, and it is the hyperosmolarity of the tear film and the inflammation of the ocular surface that actually potentiates the whole problem. So osmolarity, we all know what osmosis is, right? So when the proportion of the water is the same on either side of the cell, that means extracellular and intracellular, it's called the isotonic state. But what happens when there is either loss or there is less production of water? There is a hypertonic environment that they are suddenly submerged in, and this hypertonicity sucks the water out of the cell. And what does that mean? It means the cell becomes dehydrated. When the cell becomes dehydrated, it sets up a whole sequence of events. When the quantity of the water is less, as is the case because of high evaporation or because there is insufficient production, or because there is less water in the tear film, it raises the osmolarity and upsets the isotonic balance between the tear film and the ocular epithelial cells. In the healthy eye, the osmolarity of the tear film is the same as the blood, which is about 296 to 302 milliosmoles per liter. But in dry eye disease, this osmolarity is generally much higher. And spiky tear osmolarity at the apex of the cornea can be between 8 and 900, which is 3 times normal, which is very difficult to actually pick up because we are able to get only the tear films that is available at the meniscus or at the inner canthus. So what happens when the cell is exposed to a hyperosmolar stress? This is what happens. The normal cell that is there, this animation takes forever, gets exposed to hypertonic environment and gets dehydrated. And as it gets dehydrated, it gradually loses its shape and size, but the tissues can't shrink. So it does what it calls a regulatory volume intake and starts to take in various salts which restore the cell volume because they bring in the water with it. But because of the hyperkalemia and the hypernatremia that sets up inside the cell, there's a reduction in the cell function, and there is activation of the stress system, and there is cell damage and death. So this is pretty much what happens to all the corneal epithelial cells as the hyperosmolarity stage. So this is the tear film instability, tear hyperosmolarity, inflammation, vicious cycle of dry eye, which leads to apoptosis in the end. Now, ocular surface damage and hyperosmolar stress starts to take place very early in the system. There is the activation of the stress kinases very early, and then there's transcriptional activation, which results in acute epithelial disease, which lasts about a week. And if the dryness state or the hyperosmolar state continues beyond that period, a second stretch of activations happen, wherein the inflammatory cascades come into the picture and starts to produce a chronicity of the disease. Now, what is osmoprotection? We talk about certain tissues like the kidney, the heart, and the brain, which experience hypertonicity, and these cells protect themselves by either synthesizing or importing what we call compatible solutes. What are compatible solutes? They are small non-ionic organic compounds. That means they are not sodium, they are not potassium, they are not bicarbonate or chloride, which will interfere with the metabolism. They are inorganic, inactive compounds, but however, they produce an osmotic effect and bring the water into the cell. And thereby the cell is able to restore its volume and able to manage to do all its function. So if we go back to the same animation that I showed you earlier, the dehydrated cell had regulatory volume intake and salt intake, which caused cell damage and death. But what is an alternative that is available to it is a regulatory volume intake with compatible solutes, which restores the cell volume without interfering in the cell metabolism. And this is what is called as osmoprotection. And this is the concept that has now essentially over the last 7 or 8 years since it was mooted and published, has now taken hold, and now we have a spate of drugs and lubricants available which are following these norms. So these are just a list of some of the osmoprotectants that are available. L-carnitine, erythritol, and glycerol you've all heard of, which are largely available, but there is a whole host of them that are there. So the goal of treatment of DED is to improve the patient's quality of life and symptoms and visual function, and to prevent the patient from entering the vicious circle or to promote the exit from it. By preventing entry into the circle, you are addressing the causative factors such as systemic disease, the contact lens use, and environmental factors. By promoting exit from the vicious circle, you have to address the central mechanisms such as hyperosmolarity and inflammation. And there's an expanding pool of data which now suggests that osmoprotective effects are extremely important, and glycerol, erythritol, and L-carnitine have now been incorporated in many of these drugs. There are various kinetic properties of these compatible solutes. Some go in and out very quickly along with the water channels. Some go in medium speed, such as erythritol, and some are actively imported or removed from the cell, such as the L-carnitine. And it's this combination of osmoprotectants with different kinetics that actually work best. And the formulations have to be constructed in such a way that they satisfy the requirements of these formulations. Now, there are laboratory studies, ample number of them, which have gone ahead to show the benefits of this. So there was one study which was done by Corrales et al. And published, where they used the human corneal epithelial cells and incubated them in isotonic and hyperosmolar media with or without the osmoprotectants. And they found that the activation of the enzymes was much less in those media where the osmoprotectants were present as compared to those where they were absent. Similarly, another study which was conducted by McDermott, they looked at the osmotically regulated tear preparations versus the ones that are passive in an ex vivo porcine corneal dehydration model, and they found that the corneas dehydrated much faster in non-osmoprotection media as compared to those which contained osmoprotection. Another study which looked at the suppression or the production of activity of the matrix metalloproteinases induced by hyperosmolarity also found that the media in which osmoprotectants were available provided much better protection as compared to where they were unavailable. So there were various lab studies that were there, and there's a fair amount of clinical evidence also where these drugs have been compared with each other in various studies. There's the study by Rajpal et al. There's another study which is 5,000 patients conducted in Germany by Karchar et al., wherein they did a switchover trial, and they found that Opti was considered to be superior to the other drugs that were being used by those 5,000 patients. There were more studies conducted, but I'll just sum up very quickly. The clinical signs and symptoms after 2 to 4 weeks of using of Optive. So the conventional artificial tears have a limited impact on the ocular surface damage, so we need to work on the inside as well, and that's what they term by the dual mechanism, wherein we are not only just using as lubricants, we are also trying to support the cell from inside, and that's where this understanding comes from. More evidence is now being gathered where the role of L-carnitine in protecting the ocular surface is being looked at, and we are finding that L-carnitine concentrations actually drop in patients with dry eye in the tears, and one can see that in healthy subjects it's about 9, and in dry eye subjects it's about 3. So that tells us that there is a loss of these osmoprotectants available in the tear film, probably leading to the exacerbation of the dryness. So to summarize, dry eye is produces significant ocular surface damage even in the presence of a normal tear film, and this occurs fairly early, and this is mediated by hyperosmolarity, which is a key mechanism in the evolution of the dry eye. The cells utilize short-term and long-term regulatory mechanisms to maintain the osmotic balance. Unfortunately, the corneal epithelium and the conjunctival epithelium do not have the capacity to normally synthesize these compatible solutes. Hypotonic solutions provide only very transient relief in the system of dry eye, Compatible solutes help to regulate the osmolar balance and restore the tear film osmolarity. And so there's mounting evidence, both clinical and in the laboratory, to show the beneficial effects of osmoprotectants. And incorporating compatible solutes with different kinetic properties in these artificial tear substitutes may be more effective in protecting patients from dry eye disease. So thank you very much, and a warm invitation to the DOS meeting in April 15th, 17th at the Ashoka in New Delhi, and also to inform you of the upcoming World Society of Pediatric Ophthalmology conference that is going to come up in December 2017 at the Ashoka again. So note the dates. It's December 1st to 3rd, 2017. Thank you very much.